I wanted to be a lawyer.
You wanted to be a lawyer? Okay. I don't think he will need an introduction. He's like a pioneer in IR in India.
I never had opened out so much. In fact,
Well, there
to
is.
be a IR, you have to be a clinical radiologist first. That helps you a lot. Yeah, actually, right from beginning, since I started IR, one of the main problem or concern with us is that there is not much of awareness about the IR.
Hi guys, welcome to another episode of Gloves Off. Today, I'm so happy and I can say this tension. I mean, like you guys can see the tension on my face because I am sitting with Dr. Indushekar. I don't think he will need an introduction. He's like a pioneer in IR in India. So thank you so much for being a part of this
Thank you.
show, sir.
Thank you.
And how are you?
Well, fine. Just finished my work at hospital and then,
Okay,
yeah.
I totally know that, like, how hectic it is over there at HCC.
Well, some days it is very hectic.
Okay,
Some days it's quite okay. But anyway, end of the day you get exhausted.
yeah, that's true. And you're actually working at an onco center now, sir?
Yeah.
Okay, and tell me, tell me your journey. I mean, like, can you just brief our audience about your journey in IR or like your early days in medicine from there?
Uh, Actually, I come from a very small town called Davangere.
Okay,
Yeah. And I was brought up in Davangere from my younger days up to the college. I studied in JJM Medical College
okay,
and finished my MBBS in 1977.
okay,
Uh, then I was trying for post graduation at that level, but I couldn't get it in Davangere. So, as an adventure or exploration, I just moved to Bombay.
okay,
I had to do find different posts and working at different hospitals uh, for six months like that. They had a system there like 6 months postings for any subject. You have to work like that, but post graduation is not guaranteed.
okay,
So we used to get house posts like that. So initially I worked in neurology, and then I worked in cardiology. Then another 6 months in medical oncology, where I could actually chance upon getting a registration for MD.
okay.
And that was in Tata Memorial Hospital. So actual radiology career started in Tata Memorial Hospital way back in '82,
Okay.
and then I continued there for a year, and then moved to another hospital because I had to learn different aspects of radiology.
Yes.
I finished in '85,
Hmm.
and then came back to Davangere as a staff in the medical college.
Okay.
So that was part of the radiology part.
Okay.
But then I was not satisfied. I was very good at, I mean, quite well versed with ultrasound, which had just come to Davangere at that time.
Hmm.
And I was the main person who was handling most of this. And a lot of other investigations, old time investigations like barium meals, barium swallows, enemas, and then myelograms, IVPs, etc. We also started doing some diagnostic angiograms with limited resources.
Okay.
So, like doing an angiogram or a PTC was always there in my mind, which I had an exposure in Bombay while doing post graduation. So, Although it was quite primitive, I would say, but I had some exposure to vascular
Okay.
anatomy or doing an angiogram like that.
Okay.
Uh, I was there from 85 to 88, in fact. Then I got married in 88, and still I wasn't really satisfied with the kind of work I was doing.
Okay.
Then finally, I had a chance to work in Paris as a research fellow.
Okay.
So 1990 November, I moved to Paris.
Hmm.
So this is kind of basic things about formal education in radiology, and
So it was a research post there.
not really research, but it's kind of a fellowship program.
Hmm. Okay.
Yeah. So again, that's a wait for nearly 1.5 years from getting acceptance from Paris to landing up in Paris. So almost 1.5 years gap. It was not easy journey though. People may look at, okay, you got a good exposure in Paris, but going through that process of you know entering Paris was not easy.
Okay.
Anyway,
Uh,
destiny took me there, I would say.
you wanted to go to Paris and you applied for that, or
Hmm. No, initially I was not very clear what I'm
hmm.
going to do,
Okay.
and also concept of interventional radiology was not there. I'm
Huh.
talking about 86, 84, 7.
Okay.
Uh, we had no idea. In sitting in a small town, we had
Hmm.
no idea about interventions.
Hmm.
But somehow I randomly started contacting uh, people in Europe. So looking at the journals, whatever interesting article used to be there, uh, I wrote to about 4 or 5 people all around Europe. One in Germany, one in Paris, another in Scandinavian country, another in UK, like that. Majority of the answers were negative.
Okay.
Only from Paris, Professor Alan Roche, who was my trainer, he gave a very positive reply,
Hmm.
stating that I can be uh, going there for a fellowship in intervention radiology, and he had written about what kind of work will be available and all that. So that changed my mind. In fact, that was a spark which I considered very seriously.
Nice.
So again, the problem was financing at that time.
Okay.
Uh, what happens was, okay, you have an acceptance from a foreign university or a center, uh, that too from a very premier cancer center called Institute Gustav Rossi,
Okay.
IGR it is called.
Hmm.
And from that, it's a very prominent, and I can say this only hospital in Paris recognized all over the world at that time. Like you have Royal Marsden in the UK, and then Sloan Kettering in US. Like that, IGR is in France. So it was very famous, and fortunately, I could go there and get trained myself. And that is also a cancer center. So my initial training was in Tata Memorial, which is a cancer center. Then IGR, again a cancer center. Now I am also working in another cancer center, which is something.
Destiny.
Yeah, yeah. I can't explain how, but it's happened.
Yeah, that's true, sir. I mean, since I'm in my budding stage, like becoming an radiologist first, and then it's a long route, long journey to become an IR. But listening to you, it's actually inspirational, like, how will be pushed.
Yeah, actually, if you look at my career, I wasted almost 5 years
Hmm.
between MBBS and entering radiology.
Okay.
Not really wasted, but I
Hmm.
had to work in different areas
Hmm.
to before I could get into radiology.
Hmm.
And then, not being satisfied with diagnostic work, again trying to do something different. So at that time, there was no concept of intervention radiology.
Yeah.
Uh, for 2 years, when I went to Paris for a training, after coming back in '93, nobody had heard of intervention radiology as a subject.
Hmm.
So from that stage, we had to work.
Yeah, that's true.
So
But
I don't think you should get disheartened
hmm.
by not getting into radiology,
Hmm.
but continue to
Yeah.
focus yourself on that.
Hmm.
You should be able to get in. There are a lot of
Yes.
opportunities now opening up.
Huh. But said those 5 years that you mentioned, that where you worked in different departments, do you think that it has helped you in terms of becoming a good
Yeah,
diagnostic?
indirectly it has helped me a lot
Yeah.
because in UK, for example, you cannot enter radiology without having a general medicine or surgical post graduation.
Hmm.
So you have to do a MRCP
Hmm.
or FRCS
Hmm.
before entering FRCR.
Hmm.
That means you have to have a good clinical background. So, uh, without my knowledge, I was doing all this
Yeah.
clinical subjects
Yes.
as house post,
Hmm.
and I could learn the nuances of medicine in different ways, like neurology, medical oncology, and cardiology. So it was a blessing in disguise. Although it was not a very congenial, uh, atmosphere for me, according to Indian standards, but indirectly it is helping me. Even today, it is helping me
Yeah.
because my clinical knowledge is far better.
Yeah. That is something that will add on to an interventional radiology.
Yeah,
It's also right. Like
yeah. In fact,
when there
to
is
be
a
a IR, you have to be a clinical radiologist first.
hmm.
That helps you a lot.
Hmm. And also treating the patient from the first point, we should have a very good clinical skills with us, right?
Yeah, absolutely.
So
Because the references may come in a different way because whoever has seen the patient would have looked into the patient in their perspective.
hmm.
Like a physician will be looking at general
Hmm.
physical diseases,
Hmm.
whereas a surgeon will be looking at his own perspective, whether it is operable, inoperable, things like that. But when it comes to IR, we should have a combined knowledge of both medicine, surgery, and other specialities. So that helps you to pick up what is best for the patient.
Yeah, that's true. Even during a procedure, I was talking to my mentor yesterday. Yesterday we had a case of inferior vena cava stenting, and at that point, patient had a heart block. I mean, it was showing during the procedure on the monitor, it
Yeah,
was showing a heart block. So the anesthetist was seeing the case, and I was sitting in the console actually observing the case, since I'm a junior most person there. So at that point, I was seeing, and I could recognize it's a Mobitz
yeah,
block, and we were discussing on that. And post that procedure, I was telling sir that only. So today I've seen this case. In future, if at all, when I am doing a procedure, and if patient has a similar episode, I will not panic there. I'll know that it happens during the standing, and I will be able to manage it. I will not panic at that point without knowing like what has to be done. So
yeah.
that any radiologist should getting that exposure will help them, right?
Yeah, basic clinical knowledge is required, and also you have got to observe changes in the monitor, whatever is happening. Uh, so, to if you are not very familiar, it's better to have an anesthetist
Yeah.
at hand. So you do your job, anesthetist will do
Their job.
his, yeah,
Yes.
manage other things. We shouldn't really struggle for, like pain management or cardiac issues while doing the procedure, because you can do a better job if you are having an anesthetist at your hand.
Yes.
So it is much easier to do that than trying to, do everything yourself. And also it gives you a reassurance that if something goes wrong, there is another backup.
Yeah. And also, regarding, like back to your early life, sir, were you always interested in medicine, or how did you get into medicine?
I wanted to be a lawyer.
You wanted to be a lawyer. Okay. Then how did you get inside medicine?
Uh, in fact, uh, what happened one day was I was in SSLC, 10th standard, and my elder brothers and sisters all are elder to me. I was the last. So my father was telling you, when I wanted to study, nobody supported me, but I am supporting every one of you. But you people are not studying. At least in the family, if somebody becomes a doctor or engineer like that, he was expressing his
Okay.
kind of feelings. That time I decided, okay, I'll take up PCB. That time it was not like PCMB.
Okay.
Either you go for physics, chemistry, biology, or physics, chemistry, mathematics.
Okay.
So I changed from SSLC in the pre-university to PCB and managed to get into medical college
Okay. Nice. That's why
just
we
to
have
fulfill
you.
my father's wish.
Great.
Yeah.
And so when you went for your training abroad in Paris,
Yeah.
like when you got exposed to interventional radiology, I think it's in the year of 90s, right?
1990.
1990 you went there, and now it is 2025, and you have a program under you where you're training interventional radiologists. How do you think, like, those days back then in Europe, how the training was, and how the radiologists were exposed? Were they exposed during their post-graduate time itself, or only when they enter into super specialty they're getting exposed? How is it? How was the trend over there when compared to India?
Well, generally in Europe, what happens is, I'm just talking about Europe and more so specifically in France.
Okay.
When they are doing radiology,
Hmm.
I think the course is around 4 years,
Hmm.
radiology post graduation. In that, at least 1 year they will be posted in intervention radiology. That is how
Okay.
the students choose to come to intervention. So once in 1 year, they will be able to actually learn majority of the interventions, because quite a bit of work happens there.
Yeah.
And then once they have the training, they can appear for the European board or French board of intervention radiology. So they're already in interventional group when they're doing MD or kind of specialization. But in
Great.
UK, the things are different.
Okay.
Again, you have to do first clinical medicine, then you come to radiology, and then you do fellowship, and then get trained in interventional radiology.
Okay.
Like FRCR, you have to do, and then go for interventional radiology, almost like in India. But in France, they have a possibility of continuously doing radiology as well as intervention.
That's nice.
In fact, two of the residents who were French, when I was doing fellowship, so we were three of us. One was professor was Alan Roche, who was the chief of the service, and there were about 3 or 4 visiting faculties, and, like, and then there were residents who would come for 1 year during their post graduation, and one was along with me, Dr. Mark Sapawal, who's again now a big man in Europe, and Thierry de Beer, who is a pioneer in a lot of ablative techniques. He
Okay.
continued to be in IGR. Mark Sapawal moved to another hospital, and myself. We three were there for 2 years, and then there were other people who would come for observers post or rotation, and even from other countries people used to come to learn, like in from Canada, Greece, Italy, like that, and Egypt. A lot of people used to come to IGR for training, and I was fortunate enough to continue for 2 years.
Great.
And the entire fellowship program was funded by French government. It's not that I don't know. I was lucky enough to get it. Otherwise, it's not easy.
Yeah.
It's sponsored by the French government itself.
That's nice.
Yeah.
So, do you think in India also we should? I know that in the in medical colleges where they have an interventional radiology department, yes, they are getting an exposure like that.
Yeah.
But when we take the numbers, I don't know. I don't think there are the number of medical college which have an interventional radiologist as
Very
compared to
limited.
the other one. It is
Very,
limited.
very, very limited.
But they do have radiology seats over there. Yeah. So the radiologists who are studying over there, they're not getting an exposure to IR, right? Do
Yeah.
you think that should be added to the curriculum?
Well, there are so many branches in radiology today. Problem is that
Hmm.
you have fetal medicine, you have pediatric radiology, and different branches are there already in radiology. So students may not be interested in IR because it's kind of hard work, and many of the radiologists, when they take up radiology as a post graduation, they want armchair job, or in front of the computer, rather than looking into the patient and taking all the risks. Then you have people who are not really interested in IR. So very few people will be interested in IR. If the college has the facility of IR in their center, maybe they'll expose better. But somebody who is interested in IR should take postings at least for 1 or 2 months in the center where IR is, prominently
Yeah.
done,
Hmm.
and they get exposure to IR.
Yeah.
So also the university exams and DNB exams, if you look at, they are asking for. I mean, the questions is oriented towards clinical radiology and interventional radiology. So now more and more students are ready to come to the centers where IR is practiced, and they get some kind of exposure. At least they know what is happening.
Yeah. Yeah, they should have that, I feel. I mean, when it comes to an onco center, the role of an IR over there is very crucial,
Yeah.
right? In every system, that's what I feel. Like even in something like hepatocellular carcinoma, or even in case of a PTBD, that I mean, it might look very small. It's actually putting a stent in, but it's not. We know that it is not a small procedure, but uh, that that is actually extending the patient's lifespan.
Well, in oncology center where interventional radiology, like in HCG, what we do, 50% of the work is on liver, hepatobiliary work, and The other work is like preoperative tumor embolizations to make the surgeons feel better and uh, for good outcomes. Uh, if you look at the natural history of the HCC, the hepatocellular carcinoma, earlier people used to say, okay, HCC, no treatment, go and die. That was the trend. But now we know that we have multiple options of treating the HCC depending on the staging, depending on BCLC scoring system and all that. And we have seen people, living for more than 5 6 years easily with good quality of life. Not that they are bedridden or coming to hospital regularly. With the right kind of treatment at the right time, HCCs can be controlled uh, or downstage to have a transplant or a resection.
Yes.
So all those possibilities are there, and there are a lot of ablative techniques,
Mm.
regional chemotherapies, and then isotope therapies, and all that. So uh, it's not just that the prognosis is bad in all the cancer cases. We do have good cases, and in the sense, if we analyze properly and in treat them in proper way, I think we can salvage them and give a good quality of life.
So I don't know. I mean, from my knowledge and the survey that I was doing, I kind of feel like it is lack of awareness among patients, and I think it's the lack of awareness to refer the case to the respective department, an IR department, or among the other.
Yeah, actually, right from beginning, since I started IR, one of the main problem or concern with us is that there is not much of awareness about the IR in both in the general population and also among the medical specialists. Well, they think that when they would be coming across certain procedures in the books, but they still think that okay, it is done in Europe and America, not in India, not realizing that in Bangalore itself we are doing it.
Yeah, that's true.
That is the kind of awareness which we need to create,
Yeah,
and well, we are trying. It's a long way
yeah,
still.
it's a long way. Um, so coming back to the training part, sir. Um, so you would have trained so many IRs
Hmm.
all this while, no? So what would you like to talk about that?
Well, I think while selecting the candidates for training,
Hmm.
I used to be very careful in a sense. I would not look at their marks or grading, whatever, uh, like winning a gold medal or silver medal. I never used to bother about it because that academic achievement may not really translate to the interest in IR. So unless the person is really focused on IR, I wouldn't consider them. And
Okay.
second thing is, I never used to bother about whether they know IR or not. In fact, I would say a completely ignorant person of IR
Hmm.
having radiology degree was sufficient
Okay.
because you can mold them. If they are like blank paper, blank slate, and you can mold them in a way which I felt is proper to do.
Hmm.
Means uh, from the point of view of the skills, assessment of the patient, pre and post op procedural care, everything you can mold them if they don't know anything. If they already are trained in some way,
Hmm.
it is difficult to unlearn and then learn the techniques.
Okay.
Yeah, because most of the centers, when they are teaching the students, uh, they follow the textbook description or whatever. whatever is given in the book or in the journals. But I always have experimented on different materials, different way of using things. So because I learned the hard way of using materials and also the technical skills, I want to impart that skills which is much easier to do. And uh, most of my students who are trained under me do not follow the textbook pattern. They follow what I have taught them. So they feel it much easier.
Yes.
Yeah. So the time taken for the doing a particular procedure is considerably less, and least number of materials are used for each procedure.
Great.
Yeah. Simple example is that I use Yashiro 4 French catheter for most of the taste procedures. Majority of the other places they use either renal cobra or a sidewinder, 5 French system. Using 4 French system is much easier to handle. Of course, there is a learning curve, but then it saves you a lot of time. And hardly we have seen any complications related to the procedure with this. Because when you're handling the catheter and guide wires, there can be spasm of the vessel, there can be dissection of the vessel like that. But hardly we see any of that in our lab.
Understood.
So it's not that everything is followed according to the textbook descriptions. Certain things are totally different what we do. That's why I said if a person who is trained already, when he comes to our department, he has to first unlearn whatever he has learned
Okay.
and then come back to this.
Yes, this I have noticed. I mean, like in small cases, like right now where we are doing our procedures in Malabar Cancer Center, it's a government aided center, so they won't be able to provide all the consumables that we ask them to. But we will have to use the consumables that are available over there, and then benefit the patient because they won't be able to afford it otherwise. If they are not able to afford it, they will not be pro doing the procedure also. So yes, in training part that is very much important, right?
Yeah, you have to use different materials, no doubt about it. But you should also know what is the problem with this material and what is the problem with other material. Understand that material what you are using
Okay.
and then use it judiciously.
Huh.
That also is important. For example, if I also go to Victoria Hospital, that is I got, and there, not that every material I wish is there. So whatever materials are there, I'm going to use it. But technically, it is slightly different, which I impart to the junior interventional radiologists who is working. They learn from that.
That's
They
true.
learn from
Yeah, I mean, I can imagine because the one that you have trained is the one who took me to the, I can say, just showed me the wonder of IR actually, Dr. Junais.
Yeah.
While doing my residency, surgical residency, I had no idea about IR at that point of time in my life, and how he was approaching the patient, how he was talking to the patient and making them understand the procedure. And as a resident, he took me to the ablation and then he showed me how the ablation is being done and told me how it is, what is the procedure, and showed me the wonder of IR, I can say. I mean, just initial
Yeah.
picture,
Yeah.
and
In
from
fact,
there the journey.
in fact, Junis was a very good student. He could learn and grasp the things very fast. One of the students who grasped everything, and in 1 year he became quite proficient with majority of the procedures,
Yeah.
and that gave him confidence. See,
Yes.
what we normally do is you start from the basic First month the student will be observing what we do. Second month they start the procedure,
Mm.
and then they are allowed to continue till they have a difficulty, like maneuvering a catheter or maneuvering a guide wire. If they are stuck, one of us will assist them.
Yeah.
So by end of 3 months, they would be able to do simple procedures. And by end of 6 months, what happens is if there are two fellows getting trained, we just allow those two fellows to do the procedure. None of us will be washing up.
Nice. Mm.
By end of 10 months, they have to do it alone, no assistance. So that way, gradually they start understanding, and then they will be developing the skills. And doing alone gives them more confidence, because when they go out of the institute, there won't be any help,
Mm.
and they confidently do it.
Yeah, that's true.
Now, apart from this, what happens is they are responsible for the patient's uh, like OPD assessment. We take them to OPD assessment, then admission process. After admission, whatever the formalities and also the pre-procedural drugs, everything. Post procedure, their patients are under their care. So complete understanding of the disease and the patient is with them, and we also make sure that they follow up the patient, and then make entry in the system which we have, so that you capture the data. By end of 1 year, uh, they would have a lot of data to produce any paper or anything like that. The other thing is logbook, which is very important. Every day, whatever they do has to be entered in the logbook,
Mm.
along with the materials, what is being used, how much contrast is being used, what the reaction happened, what was the problem, everything they mention. So that when they go back to their place, they can just look at their logbook and recollect whatever has happened. So that way, it is important to educate them and train them in all aspects, not just the procedural aspect.
Understood. That's nice. And sir, when you came back to India in the initial days, what were the challenges that you faced to actually educate other specialists about benefits of interventional radiology?
Well, I came back to India in '93
Hmm.
after finishing 2 years of fellowship. Uh, in fact, I was looking for a job, and to many hospitals I went, and although they were saying encouraging words, but somehow things would not materialize. And finally, I joined Ramaya Medical College as associate professor.
Hmm.
So there also, what happened was I just went to meet my friend, and was an endocrinologist. And at that moment, he had a problem, a case like insulinoma, suspected insulinoma, but they could not prove it. So I was just talking to him. Then he mentioned about the case. I said, "No, what is the problem? We can do portal vein catheterization and preoperative localization of insulinoma by sampling, venous sampling." Suddenly, we just took note of it. And then he said, "No, no, I have got the patient. You have got to solve this. I'll take a special permission from the dean for you to come and do that." I had not decided to join there.
Hmm.
So after 1 or 2 days, he took permission, and then they made arrangements. Whatever I required, some of the materials I brought from Paris, and I did that procedure. And a lot of people were just watching, doing an angiogram, and then taking multiple samples, venous samples from various positions of portal vein and pancreatic veins. the entire staff was so much impressed. And they offered me a job. I didn't really apply, but then looking at the work and this happened. So I joined as an associate professor, and then I became professor in radiology. But I was doing both radio diagnostic and intervention at that time. So most of the clinicians would come to the radiology department, then they would come with some problem or the other, like some collection, post-operative collection, amoebic liver abscess, and things like that, biliary obstruction, GI bleeds, and all that. I was able to give them an answer, and also do the intervention for that particular. So they developed the confidence in, and slowly, the whole hospital started realizing that okay, this is a new branch and doing totally different kind of work. And there used to be on Fridays there used to be a clinical meeting every Friday. In that was there in Ramaya College. So I started presenting the cases there, clinical meeting. So there was a good exposure to all the clinicians in the hospital. So more and more clinicians used to come and ask me for a kind of solution or the problems which they have got, and then we used to have a one-on-one discussion and then proceed with the procedure, whatever. So that is one. And second thing was uh, in Bangalore, especially as a whole, there are many clubs, in the sense gut club, which is gastroenterology. This one, you have chest club, nephrourology club, orthopedic, like that. Every subject they had monthly meetings of these clubs. Every month they would meet in some place, and some cases were discussed. So I was one of the regular attendant for gut club, and problem cases were there, and I used to give my views on that, and also showed them the procedures which we have done, what is the benefit, what has happened to the patient, and all that. So in one go, I could actually show the potentiality of intervention for almost every gastroenterologist in the town.
Yes.
So that way, people started recognizing. I think even today we need to do that.
Yeah.
First thing is educate the colleagues that what IR potential of IR is, and then go to the public forum or patient, because you should not directly advertise yourself for general public, and it's wrong, ethically wrong.
Okay.
So there can be problems if you are putting up, showing up cases. It amounts to advertisement. So general public, you have to be very cautious.
Yes. Yeah, it should always go through a multidisciplinary team there, right? From
Yeah,
the
yeah,
referring physician.
yeah.
Yeah.
Well, usually what happens is if a patient gets better, they would recommend for another friend of them for the procedure wherever it is done.
Yes, that's true.
So, and now majority of the patients who come to us are uh, computer savvy, and they search in the Google, they'll find out about us. And in fact, I find it so interesting that they know more about me and the procedures rather than I myself know it.
Okay.
To that extent, they study, especially the software guys. They know almost everything about it.
Yeah, that is true. Just as ChatGPT, everything is there now.
Yeah, yeah.
But
So you have to be competent enough to answer their question. Then they get.
yeah.
So that is one way of improving the IR,
Hmm.
because so many patients are tech savvy and they would be searching for solutions,
Hmm.
easy solutions. They
Hmm.
don't want to just undergo surgery just because XYZ surgeon
Hmm.
has said.
But yeah, I mean, in my right now, what I've seen and what amazed me about the department in HCG, I'm really grateful that I have got that exposure also. I have seen the oncosurgeon, pathologist, radiologist, and IR sitting together and discussing about one case.
Yeah.
I've seen that thing multiple times over there, and I used to feel like, if this way was being followed everywhere.
Yeah, it is. See, what happens is in oncology, there is a structure. It is not a disease which can be handled by one person.
Hmm.
It has to be multidisciplinary, and then you plan how the treatment has to be. It is not just one day treatment.
Yeah.
Like GP going for a cough and cold or some infectious disease, he can decide himself what
Hmm.
antibiotic has to be
Hmm.
given. But some diseases which are chronic, you got to put all your minds heads together and decide, okay, these are the options we have.
Hmm.
Put every option on the table, and also give freedom for the patient to choose.
Hmm.
You have to be very clear
Yeah.
what are the options. Then explain the problem with the patient.
Hmm.
Okay, you have this problem. You have option one, two, three, four, and with to best of our knowledge, surgery is better or intervention is better, something like that. And you have to substantiate. Then patients will have a confidence in you and also look at the overall picture instead of just telling them that okay, you got this diagnosis which you don't understand. I say you have to undergo surgery.
Hmm.
So they won't. There's no option for them. I
Yeah.
think.
True.
Yeah, in emergency situation there is no option,
Hmm.
but not all the time.
Hmm.
I think we should be fair enough for the patient's point of view uh, to identify the problem and give them options.
Yeah.
So IR is what
Hmm.
we are going to do that only because they would have gone through so many different treatments, not finding a solution. Then they come to intervention radiologists.
Hmm.
IRs are not the first line of reference. Nobody directly comes to an intervention radiologist,
Yeah. That's true.
which is sensible. I
Hmm.
don't think it is wrong.
Hmm.
But then, as an IR, when they come, you have to be convincing for them
Hmm.
and don't give false assurances.
Yeah.
So, whatever is, you just have to explain to them this is
Hmm.
the option, this is the
Hmm.
option. They can choose.
Yes. That's true.
I mean, educating a patient should be like that,
Hmm.
not advertising or saying that,
Hmm.
okay, you got a fibroid, you go for embolization.
Yeah.
No, that is
Hmm.
not the only thing. Uh, just last week, I had a patient who was 49 years and then premenopausal
Hmm.
and small fibroids.
Hmm.
Now, what to do with that? She has gone to different centers and then everyone said surgery.
Okay.
Then she came running to me through somebody, through
Hmm.
another patient, and then she was very tensed. And I said, see, 49 years, chances of menopause are there.
Hmm.
Then there is a fibroid, all right.
Hmm.
Why do you want to hurry up? Wait for some time. If the things get worse,
Hmm.
if the bleeding doesn't stop, then we have one, two, three, four options.
Hmm.
You choose whichever you find that suitable. You have the literature. You know uh, the available literature, and
Hmm.
you can search for it.
Hmm.
Then she was convinced. She said, "Okay, I'll observe.
Okay.
I'll not go for surgery immediately because somebody had said,
Hmm.
okay, you come in April or May and I'll do the surgery.
Hmm. Yeah. Patient education is very important. I mean, even in case where at Malabar, when we are doing the procedure, it's a cancer center. So there, when an HCC case comes for days, we tell the patient like, this is not the end
Hmm.
treatment for this. This is a process to just give a medicine inside to just embolize the tumor, but the treatment option is different. We used to tell them that. We used to explain them about resection and
Yeah,
transplant and all that. We used to educate them. It's just saving time that we are doing, right? Yeah.
yeah. Sometimes uh, a taste can be simply a curative option. Sometimes it is a downstaging option
Hmm.
or controlling the disease,
Hmm.
make the life more comfortable.
Yeah.
Not that it is a cure.
Hmm.
Yeah, sometimes you do have a cure,
Yeah.
but not always. So you have to be very pragmatic and explain to the patient what options are there, how best we can manage.
Hmm.
Don't give an assurance that he'll live longer for 5 years.
Hmm.
You just have to say that, okay, we
Yeah.
are making your life more comfortable. That's it.
Hmm.
So that's what you have to understand the psychology of the patient and
Hmm.
also avoid litigations.
Hmm.
If you give false promises and doesn't happen, then there will be litigation.
I
Patients
know.
are dissatisfied.
Hmm.
So I mean, litigations against IRs are less, but it is happening now.
Yeah.
So that also is important when you are practicing.
Hmm. Understood. And sir, like when you compare IR procedure wise or consumable wise, like in a when you compare it with your 90s and now, how is the evolution of IR? Like, what do you think?
See, from the beginning, if you look at the IR, basically you are working on tubes,
Hmm.
tubular system.
Hmm.
Either you open because they are blocked,
Hmm.
or block them when if they are leaking. That's the basic thing.
Hmm.
So practically everything is revolves around that,
Hmm.
the same principle. But the material availability is different. Today we've got a lot of options. Uh, if it is simple, yeah, it's the same old method. But if it is a complex and hard, difficult to reopen a vessel, for example, it is not just simple angioplasty. Now you have got cutting balloons, you have got atherectomy devices where you scrape out the athermatous plaques like that. So every time you are actually getting a new material and adapting to the newer methods of treatment. Although the basic principle is just opening the vessel,
Yeah.
but how you open the vessel is different.
True.
Like that, you have closure of vessels for any leak. So every stage you have a different kind of material, and you should familiarize yourself with what materials to use. Uh, you can put coils in all the places.
Hmm.
You can put glue in all the places to close a vessel. For example, now something called as flow diverters have come, or covered stents have come.
Hmm.
So when there is a vessel leakage, you understand what is the best for this particular situation. The emergency situation determines what material you are going to use. So that way, a lot of improvement has happened. Earlier, there were not many catheters available.
Hmm.
Pre-shaped catheters were not available. We had to make it our own. And very stiff catheters, they would cause more dissections and all that.
Okay.
Now you have got better materials.
Hmm.
Now you have got, uh, you know, microcatheters where you navigate up to the distalmost part of the arteries, like 1.4, 1.5 French, which is less than half a millimeter. So that kind of materials which are available now makes your interventions much more challenging, and I mean, in fact, you take more challenges with those kind of materials,
Yes.
and you are getting better results.
True.
What was not achievable 20 years back, today it is achievable. And new procedures have come at the same time. So when I was doing the training at that time, TIPS procedure was a novelty. In the sense,
Okay.
very few people in the world could achieve that. It was just coming into that. So uh, there were only a couple of in the world. I would say that about 5, 6 people were able to do TIPS. They were considered as gods, like that status.
Okay.
But today, every hospital they do TIPS.
Huh.
So change of availability of the materials and constant improvement in quality of the materials, understanding of the disease process and long-term effects of the gadgets which you are using. They all determine the outcomes and long-term results.
Okay.
Tremendous improvement has happened for last 20 years.
Nice.
Yeah, and constantly we have to learn.
Yeah.
Uh, as an IR, you constantly start learning newer materials, because how to use it, each material, how to use and when to use, when not to use, all that will have to understand.
So, sir, I have a personal doubt. It's regarding tear procedure. I would like to know more about because I've heard like I'm from Kerala, so I know about my geography only. Very limited centers in Kerala are can do that procedure,
Yeah.
and I also wanted to know the beneficial. I mean, like how beneficial it is for an oncology center or an onco case.
See, if you look at tear, you are using a radionuclide like yttrium 90.
Okay.
Y90 is one thing which gives beta radiation, and you can't simply inject that. It has to be housed in a restrained manner, in the sense either you have to use a glass beads or resin beads to be introduced into the tumor tissue. Now, the indications and the entire procedure is quite complex. How it has to be done, because it's not freely available.
Okay.
We have to import it from Canada or Australia,
Oh.
where there are two companies who manufacture beads or glass beads or resin beads with yttrium in that. So you can't simply go on giving large doses of yttrium unless you know exactly how much of radiation has to go into this particular uh, localized area of the liver.
Okay.
You can't inject, right? So what you do is, first you need to do an angiogram, before that a CT scan to identify the area of involvement, whether there is portal vein thrombosis, things like that, and then do a proper angiography, and also block the blood vessels which are not taking part in the liver. That means the one which goes to the intestine, like gastroduodenal artery or the right gastric artery, they have to be blocked, because if the the yttrium goes into these vessels and they lodge there. They cause severe radiation, necrosis of the bowel wall. So you have to take care of that. And then you have to actually assess the exact volume and do a long shunt fractionation.
Okay.
If there is a shunting of the technetium 99, that is the nuclear medicine part, you cannot use yttrium. So there are a lot of criteria and method in which we can use the yttrium. And it's a two-stage procedure. And both Department of Nuclear Medicine and Intervention Radiologist have to coordinate.
Okay.
So first day what you do is you do entire study of the tumor, volumetry, lung shunt fractionation, embolization of the non-target vessels. All this has to be done in the first place.
Okay.
Then, depending on the size and volume of the tumor, you have to order for the yttrium beads, which will be sent to you from the company. For example, if you have a 5 or 6 centimeter size of the tumor, the volume has to be calculated, and if you send those details to the company, they will send you number of beads. They count the number of beads they are sending, so that you have a dose of 50 or 60, 70 grays to the tumor, or you can say becquerels. You convert into becquerels, so that on the day of arrival, there will be so much of radiation coming out from the isotope.
Okay.
That has to be utilized on the same day. If you delay it again, there will be radioactive decay. So, lot of coordination is required between the interventional radiologist, nuclear physician, and the company from where you are importing. So, two-stage procedure, lot of logistics have to be worked out. So, and also it becomes quite expensive looking at the entire thing.
Okay.
And two-stage procedure. They are useful in initially it started for people who have portal vein thrombosis when TACE is not possible. But now the indications have been extended to other cases also where there is no portal vein thrombosis.
Understood.
That's about yttrium. Now, not every patient is eligible for yttrium because there can be a long shunt fractionation which is higher. Then you have arterial portal shunting in many of the cases, so you can't use it. So that's what what happened was when we went through the whole literature and then attended the workshop on that. One thing, it is expensive, not many patients can afford, and there are also problems when you are actually trying to deliver the yttrium. So in HCG we started working on different isotopes. Why only yttrium? So I-131 was available earlier easily, and what we did is to work on I-131, use that to replace iodine molecule in lipidol, which is a contrast. Then use that itself as radioisotope. I-131 is a radioisotope which will go and sit in the tumor after hepatic artery catheterization. So that way we are able to give good radiation to the tumor. But the problem there was it has both beta and gamma radiation.
Okay.
So you have to isolate the patient for 5 to 7 days when you use I-131. Again, it became difficult for us to get I-131. Then we were looking at different isotopes. Uh, over a period of time, we realized that the concept of happy, that is, if you actually look at the tumor microenvironment, which has tumor cells, blood vessels, connective tissue, fibroblasts, everything. Now, fibroblasts in the tumor have got specific expression called fibroblast activation proteins, FAP. So, these FAP molecules can be targeted by certain ligands, which will go and attach to FAP molecules or FAP molecules. So, we call that as FAPI. So, fibroblast activation protein inhibitors. They go and the ligands will go and sit only in the FAP molecules, which is present in the fibroblasts of the tumor microenvironment, but not in normal tissue. Normal fibroblasts do not have that FAP expression. So only tumor associated fibroblasts have got that expression. So since FAPI is available, the diagnostic PET scan was done using that FAPI molecule using gallium. So gallium is a radioactive substance again, but half-life is very short. So we have been using gallium for different PET scans. So you have FDG PET scan, you have gallium FAPI scan, then there is gallium for NET, neuroendocrine tumors. Gallium is used as a Dotanox, gallium Dotanox scan. So like that, there are many of the substrates to which gallium can be attached. So when we saw the success in identifying the tumors using FAPI, we also thought of attaching lutetium, which is again a beta emitter,
Okay.
to the FAPI molecule. So we started using that, get lutetium 177, attach it to the FAPI molecule, and use this intra-arterially and inject into the tumor feeding vessel. Because it is so specific that it only goes into the fibroblast within the tumor and sits there, it doesn't migrate. So it gives constant radiation.
Understood.
So you are able to control the tumor just like in yttrium.
Okay.
Now, what is the advantage? Yttrium gives you 68 hours half-life. Radiation continues for 68 hours as long as half-life. Whereas in lutetium, it is for 7 days.
Okay.
So you are giving radiation to the tumor for 7 days at the half-life period. So it will still further go.
Understood.
Okay. That is one of the important things. Second thing is whenever there is a contraindication for yttrium, like lung shunting or things like that, you can still use this because this is a cell specific or fibroblast specific therapy. Whereas in yttrium, it goes into the microvasculature and blocks that. Wherever there is a leakage or shunting, it will go into the shunt and then go to the lungs, things like that.
Understood.
Whereas in case of lutetium FAPI, it is going to tumor microenvironment and attaching there. It doesn't know.
Nice. This is a new knowledge for me.
Yeah.
Great.
So it's a complex, theory, but it's quite effective. We have been using it.
Understood.
Yeah.
Nice.
And hardly there is any side effects with this.
Oh, with.
Yeah.
Okay. Is that being used outside HCG also?
No. Only in
Only in
HCG we are
HCG.
using.
Great. No, I really see this challenge in the other hospitals and all where um, ta- TASE is being done, but the tumor is lipidol resistant, and where the tear has to be performed, but because of the pricing or
Yeah,
but now the patients can come here to do it, right? I mean, it's
yeah,
beneficial. If it is beneficial, it should
definitely.
be
Many
ever
patients from Kerala have come.
great.
Yeah.
Yeah, nice. And thank you so much, sir. I mean, today I know the podcast was long, and I don't know. I was sitting and listening to you, like listening to the stories, like as usual. Um, Thank you so much for taking your time out
Thank
and
you.
then spending it over
It
here.
was a nice experience for me also because I never had opened out
Okay,
so much
nice.
for any kind of interaction.
Thank you so much, sir. I think the radiologists or medical students who are watching this will be they will be motivated to take a IR or
So,
come to this field. Like me, how like after seeing you, I remember the initial days like when I came there to do observership under you. So this calm person who is you're always calm. That I have noticed that like.
age makes you calmer.